Thomas Melton. We will be covering key policies included in the outpatient and physician fee schedule proposed rules. As a reminder, these are annual rules that cover payments impacting outpatient services and physician services. All the rules are set to be finalized in November or early December, and they become effective on January of next year. And here are a few highlights of the OPPS rule that you should be aware of. The first is that CMS is strengthening its price transparency requirements that were finalized in the prior Trump administration, known as the 2019 Price Transparency Rule. CMS is proposing to strengthen the enforcement actions and to also require hospitals to use a standard template for the machine-readable file. If CMS finalizes this proposal, hospitals will have only 60 days to comply with the new requirements, and we'll go more in depth about what that implies. CMS is also proposing to implement a new program that Congress passed last year for intensive outpatient service. So this is actually very good news that was included in this year's rule. For the first time, CMS is not removing any services from the inpatient-only list. As a reminder, these are services that can only be done in the inpatient setting, or otherwise CMS will deny them. In this year's rule, they're not removing anything. They're instead adding new services to the inpatient-only list because it's new codes that have been included by the AMA. CMS is also proposing to add 26 dental procedures to the ambulatory surgical center cover list. CMS is also proposing to implement some policies related to the 340B program. As a reminder, hospitals or 340B facilities saw significant reimbursement cuts between 2018 and 2022. Because of a court ruling, CMS is proposing to implement the court's decision and reimburse 340B facilities beginning in next year at 6%, our average sales price plus 6%. And they will be making hospitals whole by providing a lump sum. However, CMS is making these changes in a budget neutral manner, meaning that in order to give that lump sum to 340B facilities that saw those payment cuts, they're implementing a conversion factor reduction that will result in payment cuts to both 340B and non-340B hospitals beginning in calendar year 2025. And then finally, and this is actually somewhat of a good news, CMS is proposing to create in the future an added payment for hospitals that maintain a medicine buffer stock. So if the hospital keeps a buffer stock of medicine for 3 months, they will be eligible to an added payment. And for PFS, this year, the payment rule has both good and bad policies. I'll start with the bad. So this year, CMS is once again proposing to cut the conversion factor by 3.34%. CMS is also implementing an adult code for chronic care management services. This is a code that in the past CMS had delayed because of Congress stepping in and saying, if you implement this code right now, this is going to cause significant reductions across the PFS, impacting particularly specialties. CMS is saying, okay, we already did what Congress required us to do. Now we're going to implement this code back again next year, which is largely why you're seeing that conversion factor reduction. The good news is that CMS is proposing to maintain its current split billing rules. So this is the existing rules that set how CMS determines which clinician provides the substantial service, a substantial part of a service. And then finally, CMS is proposing to maintain the in-home additional payment for COVID-19 vaccine administration. And they're proposing to actually expand that payment if the clinician provides the the vaccine administration for pneumococcal influenza and hepatitis B vaccines. So those additional vaccinations would also be eligible for an additional payment if provided in the patient's home. Major wins also for social determinants of health and payments to navigate patient care. This includes additional payments that CMS will be providing for training caregivers and also for community health integration services. CMS will also be providing added payment for principal illness navigation service, such as navigation services for patients that have cancer and other chronic conditions. And then finally, CMS is proposing to give clinicians an added payment if they screen for social determinants of health as part of an annual wellness visit or in conjunction with an evaluation and management visit. This year's rule also included major wins for behavioral health. For the first time, marriage, family therapists, and mental health counselors will be allowed to enroll in Medicare and bill for their services. There are also several proposed payment increases for crisis care, substance use disorder treatment, and psychotherapy. Then CMS also adopted several policies in this rule to improve telehealth coverage. So for the first time, beginning in 2024, telehealth services furnished to people in their homes will be paid at the higher non-facility PFS rate. This is the current telehealth flexibility. The Congress extended many of the telehealth flexibilities, including originating site requirements, until December of 2024. But the reimbursement that we currently have was not supposed to extend until December of 2024, but actually revert to pre-COVID-19 in January. In this year's rule, CMS says, forget about that. We're going to continue paying you at the higher non-facility rate for telehealth services provided in the patient's home. CMS is also proposing to change the structure of the telehealth list, current category 1, 2, and 3 telehealth list, and extend some additional flexibilities until the end of calendar year 2024, similar to the first policy, to align with what Congress did to extend the other telehealth flexibilities. And these are the key issues that our team will be covering in today's rule. As mentioned earlier, if you have any questions, include them in the chat box and we'll be addressing them at the end. CMS is proposing to update OPPS payments by 2.8%, which is about $6 billion compared to last year, and ASC payments by 2.8%, which is about $170 million compared to calendar year 2023. And now my colleague will be covering the hospital price transparency requirements.
Awesome, thanks, Susanna. So let's start with a little background. In the Hospital Price Transparency Final Rule published in 2019, CMS adopted requirements for hospitals to make public their standard charges via a comprehensive machine-readable file, or MRF, and this in a consumer-friendly format. In this year's rule, CMS is proposing to make a number of standardization changes, including proposing to alter the standard charge display requirements, which will require providers to adopt a template provided by CMS for displaying data on their websites. CMS will also revise and expand the data elements that providers will be required to have in their MRFs, including the payer and plan name and contracting method. CMS also is laying out technical specifications provider must adopt, like ensuring that their MRFs reflect charge information in dollar amounts rather than percentages, have clear descriptions of services, including inpatient and outpatient, and the codes that are used for billing, such as modifiers and code types. Additionally, CMS is asking hospitals to confirm the accuracy and completeness of data that they have posted in their MRFs, with penalties being levied and public notices being posted for inaccurate affirmations. Providers will have until March 1st of 2024 to comply with these changes. Additionally, CMS is seeking information from the public on how to improve access to MRFs with the focus on any benefits and challenges that might be unforeseen and whether legislative alignment is necessary to synchronize consumer-friendly policies. CMS is wanting to grasp a better understanding of how these proposals might interact with current transparency regulations like the No Surprises Act, which already contain price transparency provisions. Next, we have the reporting programs. For a quick overview, these are a pay-for-performance programs. Hospitals must meet the requirements or they receive a reduction of 2 percentage points in their annual payment update. In this year's rule, CMS is proposing to modify 3 measurements to better align with CDC standardized data collection and quality reporting across different payment rules like the IPPS. First, we have the COVID-19 vaccination coverage among healthcare personnel. This will be modified in the same way it was in the IPPS rule, and CMS is looking to replace the term complete vaccination course with the term of up to date. For the improvement in patients' visual function measure, CMS proposes to limit the allowable survey instruments to minimize collection and reporting burden and improve the measure's reliability. Third, we have the follow-up interval for normal colonoscopy measure. This will be expanded to assess the percentage of patients aged 45 to 75. Previously, CMS was only capturing the ages 50 to 75. CMS is also proposing to adopt 3 measures, those being the risk standardized patient-reported outcomes following THA or TKA, and the hospital outpatient facility volume data on select outpatient surgical procedures. Both of these measures will apply to hospitals and ASCs. The third measure is the excessive radiation dose for diagnostic CT in adults. This measure was recently adopted in the IPPS rule, and AHPA plans to advocate for CMS to expand the measure to capture data on adolescents to broaden the data scope. CMS will be removing one measure, the left without being seen. The basis for removal is due to CMS believing this measure no longer provides enough evidence to promote quality of care and improve patient outcomes. Additionally, CMS is proposing technical and regulatory language updates to the rule, like replacing references to QualityNet to the ever so catchy name CMS Designated Information Systems, or CMS website. CMS is also seeking comment on potential future measurement topics for the OQR program, including quality measurement gaps in the HOPD setting, changes in outpatient care, concerns around workforce and patient safety, and digital transformation. AHPA likes to view these RFIs as a peek into the future of where CMS is going with developing new quality measures, and thought it was interesting to put in this webinar. Okay, next we're going to move on to behavioral health changes in the OPPS. As required under the Consolidation Appropriations Act 23, CMS proposes to establish the new intensive outpatient program. The IOP will be similar to the partial hospitalization program, the PHP, as it offers outpatient psychiatric services provided for individuals who have an acute mental illness like depression, schizophrenia, or substance use disorders. However, the IOP will be less intensive because patients are only required to receive 9 hours of intensive services during a week, whereas the PHP required patients to receive at least 20 hours of services to qualify. The new IOP program is meant to meet the needs of patient populations and expand access. These services may be provided in outpatient departments, federally qualified health centers, rural health centers, and community health centers. However, physicians will be required to obtain a certification of need and to make redeterminations no less than every month. Additionally, CMS noted that many opioid treatment programs, OTPs, already provide IOP services, and that IOP services can be effective in promoting greater treatment initiation and engagement, which may improve health outcomes. So therefore, CMS is proposing to establish payments under Medicare Part B for IOP services furnished in OTPs. CMS is proposing to establish 2 IOP ambulatory payment classifications, or APCs, for each provider type. The first is for days with 3 services per day, and the second is for days with 4 or more services per day. The APCs covered and the data on which payment rates are calculated differ by provider type.
All right, so now let's get into one of the hottest topics, which is the 340B drug program and the corresponding fix. And just a note, this part of the regulation is actually released, the proposal is released in a separate regulation. So if you would like a link that goes to the proposed remedy, just let our team know and we'll drop a link in the chat. So alongside the rest of OPPS, CMS has separately released this proposed remedy for the unlawful payment cuts it inflicted on 340B hospital facilities. And this happened between 2018 and 2022. CMS proposes to make a one-time lump sum payment to providers affected by the payment cuts. There's some good in this proposal, and there's also some problematic points. It's really a mixed bag. So first, in the green, AHPA really likes that they propose to include within that lump sum the additional amount that hospitals would have received in beneficiary cost sharing. It's also a plus that they propose to exclude providers that enrolled in Medicare after January 1st of 2018. And this is fair because those providers did not suffer the same cuts. At the same time, the elephant in the room is that CMS believes this must be done in a budget neutral manner. And so if they're going to give hospitals this one-time sort of fixed payment, they also propose to reduce the OPPS conversion factor by 0.5% every year, beginning in calendar year 2025. The agency estimates that this would end approximately 16 years from then, or when the previous budget neutrality adjustment of about $7.8 billion is reached. Feedback on this proposal is due in early September, and AHPA plans to comment. So if you have thoughts on the proposed fix and what it means for your facility, please reach out to our team. CMS also proposes some changes to the payment adjustment for cancer hospitals. CMS proposes to continue providing additional payments to cancer hospitals so that a cancer hospital's payment to cost ratio after the additional payments is equal to the weighted average PCR for the other OPPS facilities. During the COVID-19 public health emergency, the agency elected to maintain the target 2021 PCR of 0.89, and this was paid at the cost report settlement. This year, CMS proposes to resume decreasing the target PCF by 0.1 percentage per calendar year. So for 2024, if this is finalized, CMS would use a target PCR of 0.88 to determine the CY 2024 cancer hospital payment adjustment. The agency also proposes changes related to biosimilar biological products. Because Medicare's Part B spending for biologicals and biosimilars has significantly outpaced the spending for non-biologic drugs for the past 16 years, CMS proposes to accept biosimilars from the OPPS threshold packaging policy when their reference biologicals are separately paid. CMS's overarching policy goal here is to create incentives for efficiency and the selection of the least costly products while still meeting the beneficiary's clinical needs and protecting the long-term solvency of the Part B trust fund. And we just wanted to highlight this quote from the agency on the right that again just shows how they are thinking about this issue.
Moving now on to the proposals of the OPPS related to dental care. In case anyone needs a refresher, under OPPS, all items and services are placed into groups called ambulatory payment classifications, or APCs. For 2024, CMS is proposing to assign 229 new codes describing dental care services to various clinical APCs so as to align with the dental-related Medicare payment provisions in the 2023 PFS final rule. For the ASC covered procedures list, CMS is proposing to add 26 dental surgical procedures. And lastly, CMS is proposing to package payments for dental services when those services are performed with other covered services in order to promote clinical resource efficiencies. If you would like to view the list of the codes, you can click on the linked text on this slide once the PDF slides are made available. And onto the inpatient-only list. As a quick reminder, the inpatient-only list, or IPO list, is CMS's way of saying, hold on, the only way this service can be performed safely and effectively is in the inpatient setting. And so after clinical review, CMS is proposing to reassign one CPT code and to add 9 newly created CPT codes to the IPO list beginning in 2024. Although CMS is not proposing to remove any CPT codes from the IPO list in 2024, they are asking for input as to whether these 4 procedures can be performed safely and effectively in the outpatient setting, which would make them potentially as candidates for removal from the IPO list in the future. Again, this is just a request for information and not a proposal. So if you have any information that you would like to contribute, please reach out to myself or someone on the team. And moving now on to proposals related to the outpatient rehabilitation services. Regarding the supervision of outpatient rehab services, CMS is proposing to extend the policy allowing for the direct supervision of services to be conducted through audiovisual technology through the end of 2024. This proposal is also seen in the PFS proposed rule for 2024, which we will cover later. Furthermore, CMS is proposing to extend the list of clinicians who may supervise certain outpatient rehab services to include nurse practitioners, physician assistants, and clinical nurse specialists. And lastly, CMS is proposing to pay for intensive cardiac rehab services furnished in an off-campus hospital outpatient department at 100% of the OPPS rate, which is the same amount paid for these services under the PFS. Intensive cardiac rehab services were already site neutral prior to the 2017 application of the PFS relativity adjuster, which was intended to result in site-neutral reimbursement for services. Therefore, since these services were already site-neutral, the application of the adjuster produced unintended reimbursement disparities. So this proposal will exempt these services from the PFS relativity adjuster and return it to a site-neutral rate. And now onto a request for information regarding the reimbursement for essential drug buffer stocks. In 2022, the U.S. Department of Health and Human Services published a pharmaceutical supply chain resilience assessment identifying 86 medicines which are critical for acute patient care. CMS is proposing a separate payment under the IPPS rule to cover the costs of establishing and maintaining access to a 3-month buffer stock of one or more of the 86 essential medicines. Whilst the current RFI only considers the separate payment through the IPPS rule, CMS has indicated that they may apply this program to the OPPS rule in the future, as well as expand it to cover buffer stocks of critical medical devices. Regarding the essential medicine buffer stocks, CMS is specifically requesting feedback on the potential efficacy of the program to boost medicine supply chain resilience, the frequency with which the essential medicines list should be updated, the overhead costs incurred from maintaining the essential medicine buffer stocks, which should be covered by the proposed separate payment, and also the types of medical devices considered critical and how hospitals are currently maintaining buffer stocks for these devices.
And now moving on to the physician fee schedule rule. These are the issues that our team will be covering in the next couple of minutes. As I mentioned before, CMS is proposing to decrease the convention factor for next year by 3.34%, which is from $33 to about $32.75. As many of you remember, in the last 2 years, CMS has asked an adjustment to temper the impact of these payment reductions. Last year, they did a payment adjustment of 2.5%, but for 2024, Congress actually only instituted a 1.25 payment adjustment. Our team is advocating and will continue to advocate for Congress to once again step in and try to provide a higher adjustment similar to the 2.5% that they did for last year. What we're hearing is that there's lack of appetite for Congress to do any more payment adjustments for PFS. So we do expect budget neutrality to result in an additional 2.17% reduction because of these problems. Next slide, please. Despite not having Congress appetite to step in again and do an increased payment adjustment that increases that conversion factor, we do know that Congress is upset with how clinicians get paid and with this constant issue of the conversion factor being cut. And in July of this year, there was a group of legislators that sent out a letter to Speaker McCarthy and other leaders. And this is an excerpt from that letter. MACRA was intended to support a healthcare system with greater value to both patients and providers. But it has become evident that further reforms are necessary. We seek your feedback on actions Congress could take to stabilize the Medicare payment system without dramatic increases in Medicare spending. So they acknowledge that the law that was passed in 2015, known as MACRA, to reform how clinicians get paid, didn't do enough to accurately pay physicians and accurately reimburse for quality of care. Last year, we submitted comments to Congress with recommendations on how to reform MACRA, and we're also supporting a legislation that would tie clinician payments with inflation. Right now, the relative value units are set up by the American Medical Association as part of that RU committee, and those values don't really capture inflation, which results in every single year those RVUs being lower than what is actually the cost of providing, reflecting less of what is the cost of providing care. Next slide. So because of those changes, we are seeing both positive and negative impacts on specialties. This is just a snapshot. The impact for all the specialties is included on table 104 of the proposed rule, and we're happy to share that with you as well. As you can see, family practices, endocrinology, and clinical psychologists are estimated by CMS to see an increase in payments, whereas anesthesiologists, vascular surgery, and interventional radiology are supposed to see a decrease. And these, of course, are estimates. The actual impact may change. Next slide, please. And now Cherie will be covering those added payments that CMS is proposing to address social determinants of health.
Thank you. CMS is proposing to create new G codes for services that are aimed at addressing health-related social needs. And you may see this term come up a lot in the proposed rule, HRSNs. That is what they're talking about. CMS is specifically proposing to create both a new G code for SDOH risk assessment, as well as codes relating to community health integration, or CHI, you might hear, or principal illness navigation, PIN. These are the new codes that CMS proposes. First, CMS proposes to create a new HCPCS code on the left that is related to SDOH, and it's going to capture the administration of a standardized, evidence-based SDOH risk assessment. And this can be done between 5 to 15 minutes. CMS proposes the following requirements have to be met in order to be able to bill under this new code. First, the SDOH risk assessment has to be furnished by the practitioner on the same date that they furnished the E&M visit. These needs identified through the risk assessment need to be both documented in the medical record, and they could be documented using ICD-10 codes, the Z codes, although CMS is not requiring that. They want that this need needs to be linked somehow to the management of the patient's care or the chronic illness that's being managed. This can be done once every 6 months, and there would be a direct crosswalk to the existing HCPCS code G0444, screening for depression for 5 to 15 minutes, with a work RVU of 0.18. The next set of codes that CMS proposes are for CHI services that are performed by a certified or trained auxiliary personnel, which does include a community health worker under the direction of a physician or another physician practitioner for 60 minutes per calendar month to address SDOH needs that are identified in the initiating E&M visit. One practitioner can bill per beneficiary per month, and that practitioner can separately bill for other care management services during that same month if the time and effort are not counted more than once. There's a version of this code both for a 60-minute initiating visit and a 30-minute one. Similarly, the PIN-related proposals are also a 60 and 30-minute version. These are navigation and support services for patients that have serious high-risk illnesses who may not have other SDOH needs. And so some examples of this could be referring patients to appropriate supportive services, providing information about cancer clinical trials, or coordinating that complicated care transition among providers. Now moving on to the Quality Payment Program. The Quality Payment Program, or QPP, seeks to reward high-value care through the Merit-Based Incentive Payment System, MIPS, and Advanced Alternative Payment Models, or APMs. In this year's proposed rule, CMS is proposing updates to both arms of the QPP. Here's a snapshot of some of the high-level changes CMS proposes. Across the QPP, the agency is proposing some changes that it hopes will continue to move ACOs towards digitally measuring quality. And so these include the addition of 14 measures, the removal of 12 measures, and substantive changes to the 59 existing measures. If finalized, the quality measure inventory would then contain 200 quality measures. Data completeness changes, and proposing to require that vendors of CAP surveys administer a Spanish survey translation to patients that are Spanish preferring. So first, let's dive into MIPS and MIPS's MVPs, their value pathways. The MIPS program is one of 3 tracks housed within the QPP, and its goal is to migrate Medicare Part B providers into a performance-based system. Beginning with the 2024 performance year, CMS proposes that the prior period used to identify payment thresholds be a span of 3 performance periods, which would be from 2017 to 2019. This would increase the performance threshold within MIPS to 82 points for the 2024 performance period. Also, changes to APMs. CMS proposes many changes here that are pretty technical in nature, but we want to make sure to especially draw your attention to the first bullet, which is on the 75% threshold. CMS proposes to remove that threshold for the use of CHR and specify that APMs must require their use. This is where we anticipate and are already hearing the most policy discussion. CMS also proposes to make qualifying APM payments determinations at the individual eligible clinician level. Originally, this was only allowed at the APM entity level. They would freeze the QP and partial QP threshold percentages for both the payment amount and the patient count methods, and affirm that QP threshold percentages will increase consistent with the statute, and codify the transition to differential PFS payment updates for QPs versus non-QPs beginning in payment year 2026. Within MSSP, we also have a few proposed changes. The Medicare Shared Savings Program is a voluntary alternative payment model that gives providers the opportunity to create ACOs and earn bonuses through shared savings. Participants can select different participation options. CMS proposes to update the quality performance standard and reporting requirements under APM's performance pathway. And under this, APM or ACOs would be allowed to report on only their Medicare beneficiaries through Medicare QCMs. They also propose to expand the window for beneficiary assignment, update the benchmarking technology, apply the same HCC risk adjustment model used in the performance year for all the benchmark years, and make refinements to the AIP program requirements. And you can click the link there and it'll take you right to the section on the proposed changes to the shared savings program. CMS also proposes to add a third step to the stepwise beneficiary assignment methodology that better reflects the role that nurse practitioners, physician assistants, and clinical nurse specialists play in primary care delivery. CMS would also establish a new Medicare CQM collection type beginning with performance year 2024 and provide ACOs with a list of beneficiaries who are eligible for the CQMs within their ACO. Now, in order to get that list, the ACO has to first request the data explicitly for the purposes of population-based activities relating to the improving health and reducing healthcare costs. CMS proposes to modify the calculation of the regional component of the blended benchmark update factor for agreement periods beginning in 2024. This cap on regional risk score growth would be applied independent of the cap on an ACO's own prospective HCC risk score growth. And the policy would result in an increase in the regional component of the update factor for ACOs located in regions with regional score growth that's above the cap. CMS believes that this policy will strengthen incentives for ACOs to continue to participate in those regions. The proposal on AIPs is to allow ACOs to advance to two-sided risk within the basic tracks glide path, beginning in performance year 3 of the agreement period, and modify the recoupment policy to recoup AIPs from shared savings of an ACO who renews early, instead of recouping payments directly from the ACO as it is now. Again, an RFI that gives us the opportunity to both influence and get a peek at CMS's thinking. They are looking specifically for comments on the future development of a higher risk track, how an ACO's prior savings are accounted for, and any potential modifications that they could make to positive regional adjustments, refinements to the recently finalized accountable care prospective trend and the three-way blended benchmark factor, and any approaches to promote collaboration between ACOs and community-based organizations.
Looking at the remote monitoring sections of the PFS rule, regarding the remote monitoring services, CMS is proposing to include certain remote monitoring and navigation services to the General Management Code. And before COVID, CMS had required the direct supervision of a billing practitioner when an auxiliary staff member was obtaining beneficiary consent before chronic care management services could begin. CMS is now proposing to make permanent the flexibilities introduced during the public health emergency. And now moving on to the telehealth proposals. CMS is proposing to implement these telehealth-related provisions of the Consolidated Appropriations Act through the end of 2024. Again, these slides will be made available to you at some point, and you'll be able to take a longer look at that list. Beginning next year, CMS is proposing to consolidate the telehealth services list by replacing the 3 categories with 2 new categories, permanent and provisional. They will also be refining the evaluation process for new categories which may be proposed in the future. Any services added to the temporary Category 2 or Category 3 lists during the COVID-19 public health emergency would be moved into the provisional category. And lastly, CMS has no stated time frame for removing the provisional codes from the telehealth services list. As a reminder, beginning in 2024, CMS will be discontinuing the 95 modifier and will be implementing the use of the place of service or POS codes. POS 2 will be used for telehealth provided outside of the patient's home, and POS 10 for telehealth provided in the patient's home. Regarding telehealth payment rates, CMS proposes for POS 2 to be paid at the facility rate and for POS 10 at the non-facility rate. Other telehealth proposals include suspending the limitations for certain subsequent visits and consultations, allowing teaching physicians to have a virtual presence when services are furnished via telehealth. Think of this like a 3-way telehealth visit. They also propose permanently eliminating the in-person injection training requirements for diabetes self-management training and to expand the list of eligible DSMT providers. Lastly, they propose to permit opioid treatment programs to furnish periodic assessments through audio-only telecommunications through the end of 2024.
Okay, so moving on to some of the behavioral health service proposals within the PFS rule. In alignment with the CAA of 2023, CMS is proposing coverage for marriage and family therapists, MFTs, and mental health counselors, MHCs, who will be allowed to bill at 75% of the psychologist rate. They will be allowed to enroll following the final publication of this rule and will be added to the list of RHC and FQHC practitioners. Additional changes include creating reimbursement for psychotherapy for crisis services with 2 new G codes, with the payment set at 150% of the office setting rate. CMS will also expand who can bill for health and behavior assessments by allowing clinical, social workers, MFTs, and MHCs to bill CPT codes. Lastly, CMS will look to improve payment for time behavioral health services by improving the accuracy of evaluation by applying an add-on code that is determined based on the inherent complexity for services. CMS is hoping that this adjustment will help address the behavioral health clinical workforce shortage. CMS also noted that it will continue to evaluate the process used for developing relative values under the PFS for behavioral health services to ensure that the value it uses accurately reflects the resources involved in furnishment. And CMS welcomes any comments on the evaluation process. Next, we have the split or shared EM visits. A little background, back in the calendar year 2022 rule, CMS finalized a policy where the physician or the NPP who performed the substantive portion of the visit will bill for the split or shared visit. Here they define substantive portion as more than half of the total time. In the 2023 rule, CMS delayed the implementation of the new substantive portion definition until calendar year 2024. That brings us to this year's rule, where CMS is once again proposing to pause the implementation through at least December 31st of 2024. CMS believes that the proposed delay allows interested parties to have another opportunity to comment on the policy. CMS is interested in hearing about how facilities are currently implementing the policy in their workflows, and how can CMS better account for the services of the billing practitioner in team-based clinical scenarios. CMS also acknowledges that the CPT editorial panel is considering revisions to aspects of the split or shared visits, and due to this, CMS will review any changes and consider whether a further implementation delay is beyond 2024 is needed. CMS noted it will address any changes in future rulemaking. And lastly, we have the appropriate use criteria program. The adoption and implementation of the AUC program has been a long time coming, as it was originally mandated in the 2024 PAMA Act. However, CMS is now proposing to pause implementation and rescind current AUC program regulations. CMS claims this is necessary because the agency has exhausted all options for operationalizing the program, and that the agency's existing Medicare claims processing systems is technologically incapable of executing real-time claim processing in a way that complies with the prescriptive statutory requirements of this program. However, CMS does continue to encourage continued use of these tools, as it believes they are beneficial in assisting with clinical decision-making. And that concludes the webinar for the OPPS and PFS proposed rules. Thank you for listening today. And if there's any questions, feel free to unmute yourself and ask now, or you can send us an email and we'll be sure to get back to you.
All right, thank you so much, everyone. We'll have the recording available and we'll also include it in the next policy brief newsletter. We will also be adding to the chat additional files and tables that we referenced during the presentation. Again, if you have any questions, let us know. AHPA plans to submit comments on this proposal. So if there's any specific policy that you have concerns or that you have recommendations that you would like us to relay to CMS, please share them with our team. And that way we can try to also capture your comments and include them in the recommendations of CMS. Yes, the recording will be available and we'll share it with everyone that was invited. All right. Have a wonderful day, and everyone that is from Florida, hope you stay safe in this week. Thank you.